G'day and welcome to today's episode of Endo Untangled. My name is Alicia Macro. I'm a GP with a special interest in pelvic pain and endometriosis, and I'm joined today, as always, by my lovely co-host, friend and accredited exercise physiologist, Cherie Noble. And we have a special guest today who is Laura Grace, who is a registered psychologist from Brisbane, who works primarily with people who experience pelvic pain, and we can't wait to have a really good dig around in this enormous topic. Laura Grace, welcome to the podcast.
Welcome. Thank you. Thank you for inviting me.
Laura, we'd
you
love...
know I'm passionate about this.
Yes, we do. I know that you've been following our podcast for a little while. I'd love to hear a little bit more about you, though. Tell us about how you ended up working in this incredibly complex space.
So I guess I did placements in my university degrees. I have a background of a health psychology master's. I also did a clinical psychology master's, but health psychology has my heart. So the idea of, people existing within systems and the impact that chronic health has on your body and your life and the ripple effects of that. And I kept, as I went through these placements and then into my work life, meeting these incredibly strong, thoughtful people who were very adept at navigating the rest of life, but pelvic pain was having this huge impact, and they were quite often suffering in silence, had been for a long time. And time and again, I heard this story about feeling dismissed or unheard, and it really kind of drew me in. And I have lived in this space now work-wise for quite some time, and I'm incredibly passionate about it. I love it.
Wow. Yeah, we hear that a lot as well. And I can imagine, well, I can't imagine, but you get a sense of what that dismissal and even navigating what a chronic illness looks like, how much of a burden that puts on our nervous system, which then contributes to what we call pain perpetuators that kind of keep it going. So, do you want to start with why psychology matters so much in pelvic pain and how you can influence this?
Yeah. And I think, it's important. This is such an important question because people are often unsure about seeing a psychologist when they're experiencing pain. There's often the stigma around it, when really, we have this brain that is scanning for danger. It's always scanning for safety or danger. It's a primal thing. And if the nervous system has learned through sensations, movements, or experiences that, these can be threatening, then it amplifies those pain signals. And so we have this overactive nervous system that it can't calm down within a medical system that's always investigating or seeing one symptom at a time rather than a whole picture. So dismissal quite often or sometimes can be that a clinician in front of them only has part of the picture, right? Not the whole picture. It's not necessarily intentional. Sometimes it is careless. Sometimes it's not intentional, and it is purely because the picture is still emerging. But over time, this nervous system then becomes sensitized, and it means that the volume dial of that pain gets turned up. And so those things that would usually feel mild might feel really intense, might be those danger signals saying, pay attention to me or else something bad is going to happen. And so, quite often I hear things like, well, does it mean that it's in my head? It lives in your nervous system, but your nervous system is physical. It's within your body, right? But your brain can have an influence over that. And so there's a difference between the impact we can have via the brain and the nervous system and something being in your mind. We're not creating pain in our mind.
I think that's such an important distinction. And we often... we talk about wayfinding our way through this and getting a sense of understanding and making sense of our situation. And we do that as best we can. And sometimes, I can see it even physically where a light switch will go on. We'll be discussing, the perpetuators of pain or things that are happening. And you do see that relax of the shoulders and just the whole system going, oh, that makes sense. Or I'm seen, I'm heard, I'm making sense of this situation. And that can even on its own start to dial down, which I love that analogy. I talk about that all the time, sort of turning down. What does your what does psychology or the way you practice, like how does that add to that, or what else what are you doing with your patients to, work on this sort of deeper, I guess?
Well, and that's interesting because there's so many layers to that.
No, it was a big question. just explain everything. But where would you start? Yeah, in a nutshell. I know I did a really bad gag there for anyone watching. But yeah, like where would you start?
Yeah. So if we're thinking about it, I always start with safety. No matter who's in front of me, safety has to be first and foremost. In everything I do, safety is woven through that, because if we can introduce a level of psychological safety and then somatic safety or safety in their body, then it's going to have this ripple effect, right, on the nervous system. And even if we just start with the psychological safety, the ripple effect can be quite calming. And it tells the body that the alarm system isn't what it's perceiving it as. It isn't the danger that it seems, the kind of fire alarm going off.
And what does safety look like? Does it look different for different people?
Yes, definitely. So there's certainly, if you think that anybody that's been in pain has had these danger signals kind of, assaulting them, slamming them out of nowhere, right? And so there is this heightened nervous system, this heightened sensitivity going on. It's the burnt toast analogy, right? It's the fire alarm going off when you've only lightly browned the toast. It's not yet. It's become sensitized and it's noticing any smell of cooking or burning. And so then what we're looking at is the individual differences between that. So if there's trauma in the background, then, we want to keep that in mind, that somebody is going to be looking for signs of danger more vigilantly. If we have a neurodivergent brain, then we're going to be processing that pain differently. If someone has had a long journey to diagnosis and intervention, then they might have had repeated interactions with the medical system where they felt unheard or dismissed, or they might have dismissed their own symptoms for a period of time. It certainly happens that when it's gone on for decades, you can find somebody that's been sitting there for quite some time, assuming that they just need to, this is just part of being a woman and we just continue on. And so it's looking to what factors are influencing their sense of safety, and that's such an individual thing.
And do you find, Laura, I think that what we see is that sometimes people don't even recognise this. They're not even making the connections between, I've been navigating the system, I've been managing a chronic illness for such a long time, and just think it's something that they have to get on with or put up with, and not even recognising the influence that's having on their nervous system, which is then having an influence on their experience of the world and pain, even just in that, without even going into, I think we should be delving into, trauma and neurodivergence, but even someone who's just been navigating that system and not recognising that not everyone's doing that, and that's having a real impact on our level of safety. And I don't think we put those terms together. Would you agree with that?
Yes, definitely. And I think without taking into account any of those individual factors, it's something that keeps coming up time and time again. And I hear it in both individual and group therapies, this idea of the good patient role, that when the patient is going into any medical setting, they are really needing that help. And so there is a power dynamic at play, which means that people then try to present a certain way, not anxious, not distressed, not looking for medication, not looking to be overly surgical or, avoidant. And so as soon as they enter that room, no matter how much as a clinician we try to be warm and collaborative, and there is that power dynamic at play. And so when people have been engaged with that system for a long time, it does tend to have an impact on their nervous system. They're going into every appointment like that, but also they're maybe not getting across their experience of their pain because they are playing it down to some degree, or their outward presentation doesn't match what they're verbally saying.
Yeah.
They're not demonstrating the pain in the way that we expect them to.
Yeah. And I think there's a lot of talk nowadays among clinicians around burnout. But what I've started to realise is that the patients that we see, they're predominantly women, but other genders, who are coming in with a long story of pelvic pain and dealing with the medical system is that they're burnt out. They are burnt out from the system. And you talked about, I guess, some of the drivers of that, including that fragmentation. So if you're seeing someone who's a subspecialist in one area, they're really only dealing with that area, which is fine. But if you've got sort of 10 swinging balls, that's not going to work. And sometimes that's not even acknowledged. It's like, well, I've dealt with your bladder problem, but you're still not better. Like, what's going on there? Or surgically, we've dealt with this and you're not better. So do you need more surgery, or are you a bad as you say, are you not fulfilling your patient role by being a good patient and getting better after whatever we thought would help? That's burnout.
Yeah. It is. And we see it as well. And when it's been going on for a long time, I can see clients disengage from the medical care for periods of time because they just can't take anymore. Yeah. And whether that be the physical touch and the interventions and the medications, or whether it be the interactions and the requirement to mask and put on a face when they go in. And they're so frightened of alienating that professional in any way. It's exhausting. It's exhausting for anyone.
So if we're talking about safety in practice as practitioners, and I suppose what a patient should expect going to see a practitioner, whether it's a psychologist or a GP or an exercise physiologist or anybody else, let me flip this question and say, without the big bad things like, real medical harms and those sorts of things, what does safe practice look like then?
I mean, there is individual differences within that, but if we were to take a really general approach to it, then what I'd be saying is a really permissive environment, an environment where you're, as the clinician, curious, where you're asking questions, where you're not necessarily assuming pain science knowledge has landed, or that they have the capacity to engage in what you're suggesting. And so really seeking to understand, first and foremost, when they walk through the door, whether they feel able to show up authentically in your room. And some of that is our own nervous system, like we're the anchor within that room, right? If our nervous system is regulated, if we are authentically showing up and wanting them to feel safe, and we regulated our own nervous system before that, we're an anchor. But also it's that curiosity. It's what, that validation that I acknowledge the journey that you've been through, this experiences that you've had. First and foremost, your pain is very valid here and I want to help. What would make this feel safer for you? And sometimes it's that simple question, and they might not answer in that moment, but they go away from that appointment thinking this person is interested in whether I feel safe in their care. It's huge.
Is there anything you do in particular in your practice along those lines of, I'm sure there's lots of things that you do to try to make sure people feel safe, or how do you approach it?
Yeah, so my whole room is set up for this. So I have soft lighting, dimmers, I have lamps, working on natural light. It is soft, fluffy things. It's being able to control the air conditioning. It's weighted cushions. It's fidgets. For anxious folk, neurodivergent folk, whoever needs them, right? It's about me asking about experiences beforehand is one of the first questions I have. Were they good, bad, or neutral? But in doing that, what I'm starting to do, even if they're not particularly forthcoming, is hear whether their experiences with psychology have been positive, or whether their experiences more broadly have been positive. And then I'm automatically going, okay, well, if not, there's a level of safety that needs to be met here. It's also a pacing thing. So when I talk like this, I'm very passionate about what I'm talking about, and I talk quite fast. But in there, I'm conscious of the pace of my voice, the tone of my voice. I'm talking about giving permission time and time again to go at their pace. So, if you feel comfortable, what I'd really love to know about is this. But if you're not, we can talk about that another day or when you're ready. And that can translate into a lot of different disciplines in those micro consents time and time again, right? And the full warnings of transitions between one stage of the appointment and the next.
I love that term, micro consents. Just like checking in.
About it.
Checking in.
Yeah. We always think about it in that signed box from a liability point of view, right? But if we're thinking about the safety, we're thinking about all of these many, many moments of micro consents, and we worry about being repetitive. But some of the best clinicians I've ever gone to myself have found authentic ways to just touch in on that. And it might be 30 times in a half an hour appointment, but it's done so authentically that even someone without a trauma background is going, well, this person cares. It's not repetitive, no matter how much we fear it might be.
There's a few key points there. So I just want to reiterate, like, our physical environment can impact, our level of safety, which you've really touched on. And I think that that's something that maybe a lot of both patients and clinicians maybe aren't recognising. I know Alicia has a practice that's, Thrive Family Practice, which is set up so that it feels like home, that it's, I mean, it's still a clinical environment, so there's that level, but just, getting that sense of safety of, walking and feeling comfortable. You also mentioned, like, the language that you use is really important, and asking questions, like being curious rather than and getting that buy-in. And it's really interesting that I'm thinking about this from a lens of my profession, exercise physiology. We're constantly touching a patient, generally to help cues and things. So I'm so used to saying, I'm just going to do that. Is that okay? I'm just going to, because we're dealing with the body constantly. It's something that I've probably taken for granted. So I think that that's a really important thing to bring up for clinicians and patients, so that they know what to expect as well, that you can actually maybe from a patient perspective also articulate, oh, can I just have a minute? Or, but also clinicians recognising those cues of, I might be going too fast here. Do I need to let this person digest what's going on, and giving them a minute, and it's okay to pause.
Absolutely, yeah. And so I think we're talking about safety in care, but we're also talking about trauma-informed care, and they overlap, I guess, which I think is a helpful segue to actually, all right, let's have a think about how trauma sits here. And because I know that's certainly something that's very important in your work. I wonder if we could start by just perhaps if you could tell us a bit about, well, what trauma might look like, and then also how it might affect someone's experience of pain.
Of course, yeah. So trauma is anyone's experience of something as traumatic. It doesn't have to make sense to us. It doesn't have to seem logical. It's how they experienced it. And this can be something that's relational. It can be something that's context specific. It can be something from childhood. It can be something that's happening now in the interpersonal relationships. And it can be medical trauma as well, as in that, as we talked about, these kind of repeated exposures to environments where they're not the ones in power. And so what this does then is it creates a really hypervigilant nervous system and brain, right? It is looking for danger to try and protect from any further harm. It has learned the world, or this context is not a very safe space. And so, they're protective. It's protective to kind of watch for these cues. And those cues can generalize from that very specific intervention, say in a medical setting, or that very specific person in their lives, to anyone that smells like them, or any setting that feels the same way. And so then those cues come in hard and fast, and the body reacts before the mind has a chance to think it through, to cognitively understand it. And we want that to happen. We want the prefrontal cortex to shut down, and for them to be able to go in fight or flight when they're genuinely in danger. But what that means is they can't make sense of situations, or can't separate out situations where that isn't happening again. And it's just a really protective part of the brain and body, which is beautiful. We want it. But when it's been kind of sensitized by experiences, we also need to kind of make it not so trigger happy. And we need to calm the system down and the nervous system down. What that can mean with pain is that when there is a danger signal of pain, it is going to pay attention to it, and it's going to look for any tiny cue, any muscle tension, any shift in temperature, anything that feels off. And instead of being able to recognize, okay, well, this isn't acute pain that requires my attention right now, there is this constant hypervigilance to the noise, the pain noise that's coming in. And so it impacts their emotional experience of the pain, that this is now really distressing. And so we go in a cycle. And so it's much harder to learn that pain may not be a signal of something that's very, very wrong right now, or that is your body adjusting to a new normal. Sometimes there very much is an acute danger, and then there's this reinforcement, right? That, see, I have to be hypervigilant. And this is even more so in this context because the time from first symptoms to diagnosis is huge. And so quite often when they do get that validation with a trauma background that there is something wrong, it's reinforcing that if I don't pay attention, something will be missed for another 7 years. And so it is this hypervigilance that puts their body into fight, flight, or freeze so much of the time, and the muscles tense, the heart races, and it's not conducive to A, calming that nervous system, but B, turning the dial down of that pain.
And then really influencing their experience of that pain, and also fatigue. Like, it's exhausting, isn't it? And that's why we see so many patients with these excessive levels of fatigue and not being able to function.
So how do you navigate that with a patient, someone suffering with pelvic pain, that difficult, walking that difficult line around, I need to be vigilant enough that I'm not ignoring something that's medically important that I need to be paying attention to, while trying to also keep in mind that there are those sort of micro events happening that are probably not dangerous or harmful, that I need to kind of be able to sort of dial down. How on earth do you work with someone on treading that line?
And it's difficult, right? Because with these sorts of conditions as well, there is quite often flares to things that is sometimes overlapped with other whole of body conditions. And so it is important that we don't just stop listening. And so quite often it is in the feedback that they get from clinicians, as in, okay, these scans show this, we have to sit with that. And then within therapy, we'll then work with adjusting to that idea, right? That this is a safety signal, not a alarm signal. What's tricky about that is that sometimes they do need a little bit more reassurance and a little bit more concrete evidence to start to recognize those safety signals, to be able to let them in. And I think some of that is actually the trusting environment with their clinicians. If they're feeling like this person is authentic and frank with them, they're able to take that information, be confused by it potentially if their body's telling them something different, but they're able to take that and make sense of it then in therapy.
And if we're just looking through a trauma lens, Laura, I'm not sure whether you find this, but I do find people kind of judging what trauma is and what level of trauma they've experienced. So, because as you kind of alluded to earlier, trauma can show up in many different ways. And so if they haven't experienced what they consider a big trauma, then they don't.
There's big T trauma,
little T trauma. Yeah. Can you talk a little bit about that? And what you see?
Yeah, so, the kind of big T trauma, or the thing we recognise in society a little bit more, is those single incident, big traumatic, they were in a flood, or they've had a car accident, or there was this sexual assault. And all of those are very important, and the body does react to that. But what the body also reacts to is this drip, drip, drip of experiences that are felt as traumatic, and they can be the ones that sneak through that we don't necessarily recognize. And that can be the emotional neglect of a parent when they're younger. Everything is provided for, and certainly in generations before us, the emphasis was on practice practical parenting, right? They're fed, they're clothed, their healthcare is taken care of, their education is good. But was that emotional kind of presence there and attunement to their needs? Similarly, in relationships as an adult or in workplaces. And it's something that happens a lot in their experience with the medical system as well. These small moments where they feel unheard, where they feel that they've been dismissed or that it hasn't been taken as seriously. And so it looks different. It's not necessarily any less important. It has the same impact.
And it sounds like it can have a cumulative effect.
Yeah. And in actual fact, they'd learn over many experiences not to trust, right? They've learned over many experiences that safety isn't something that is guaranteed.
It's heartbreaking, isn't it, when you think about it? And I think one of the other causes of, it could be big T or little t trauma, is in one of the other topics we were hoping to cover today, which is how neurodivergence might play into someone's pain experience. Because, of course, something like autism or ADHD in women often is not acknowledged or picked up. And then it impacts the way that someone might interact with the health system and also how they might even just interpret their own symptoms. And no one is actually even noticing that the sort of things that are happening are harmful to that person's nervous system.
Yeah, and which adds to that good patient. Like if you're someone who's not experiencing your body in a way that makes sense to you, let alone trying to explain that to something else. I could imagine that level of anxiety going into an appointment, being asked about your pain and your symptoms and you're like, I don't know, I can't really pinpoint that. Or some things are heightened, some things aren't.
Yeah, don't even
navigating that as a patient.
So how do you look at neurodivergence in your practice working with people with pelvic pain?
Yeah, I think this is a really important one that I'm passionate about because we're seeing this explosion of identification of neurodivergence in women, which is welcomed, particularly autism and ADHD. It influences on so many levels in that we've got a higher co-occurrence rate of pain. We've got a higher co-occurrence rate of things like EDS, MCAS, POTS, which, we've got that overlap going on, a need to interact with a very neurotypical medical system. Yeah. And then within that, what we've got is a heightened sensitivity processing, right? And so this can mean a couple of different things. It can mean that they experience their pain and all of the sensations, the fatigue that go with that at a really heightened level. It can also mean that they experience it in more of a muted way because they have, from being very, very young, had to tune out the sensory onslaught of the outer world. And so have become very adept at tuning out the noise and the sensory input. And so that can mean that those patients don't actually hear the pain till it's a 7, 8, 9, 10. And we've missed that window to kind of catch it before it escalates, right? And so pain flares kind of tend to come out of nowhere. And then we've got that demonstration of pain. It can be not how clinicians expect. And so it might be that someone can seem very calm, very together, but they're talking about their pain being a 10 out of 10. And certainly for my autistic clients, that's the case. You really have to take the words at face value because sometimes facial expressions, voice doesn't change in line with that. And we're expecting very neurotypical presentations of pain. And so sometimes that gets missed and can contribute to that dismissal. But as you mentioned there, Cherie, there's also this layer where you've got a group that are very good at masking and they go into a situation where they want to maintain that care from that clinician and they can slip into that good patient role better than anyone. And so there's all these moments where it can be missed, all these moments where they maybe are not as aware of what's going on in their body, particularly if, their sense of their internal bodily cues is muted in some way or not as strong. And then demonstrate them feeling heard. And when they receive some sort of feedback, because they are more hypervigilant to those social cues, they are used to decoding or reading And so then any sign that it is not being received well or is not being understood or heard in the way that they needed to, it can be that shutdown that happens in an appointment and back into that good patient role.
Mm. And are there things as clinicians that we can do to help neurodivergent that people feel more safe and more comfortable in this environment? I know we talked a little bit off air around coming at it from curiosity and asking. And I did ask you because I do try and ask people at the start, how can I make this environment more comfortable for you? Or just acknowledging, do we need the lights off? Do you need some background noise? Those sorts of things. And I've said that I've come at it from a lived experience lens. So I'm only looking at it from my perspective, which I felt like, is that the right thing to do? But you mentioned that was kind of a good thing to ask the questions because it is very individual. Is that right?
Yeah, it's very individual. I think we want to be mindful of not looking at an umbrella of neurodivergence and rather going, okay, well, this might be a factor, much like other individual factors, but being curious and asking those questions, like, what does your brain and body need to be able to do this work? What does your brain and body need to be able to be in here? Some clinics will actually incorporate that into their intake forms, whether it be, have you ever wondered whether you're neurodivergent, or it might be additional questions that ask around, what would work best with their brain when it comes to lighting or noise or timing of day, communication between the clinics. So, a lot of people don't like phone calls, and yet we persist with phone calls. So there are other avenues. But then I think also, when we think within the appointment, and I know before you mentioned, Cherie, about being very touch-based in your role, those kind of transitions before the micro-consent. So what we'll do is this, and then in a few moments, if you're comfortable, we'll do this. And then, or, would you like to, or we can explore, we can see what's going on here. And then as you get up to that micro-consent, they've already been prepared for that transition.
That can take some time, can't it? That can take some time to kind of think, okay, this is what's going to happen next. It's not that immediate kind of flick of the switch where it's like, all right, we're doing this now. And you may not even have time to contemplate whether you want to have consent to do that.
Yeah. So then are we answering from a good patient role, or are we answering from informed consent? Right?
Yeah.
And so it's that nuanced level of it. And I think also, it can be quite a shock sensory-wise. If they haven't yet adjusted to this is what's going to happen, they might say yes, and suddenly it's happening to them. The other thing is to tie everything touch-based to purpose. So, not just the rationale, but this is what we will understand from this. This is what you'll take away. This is what this will help us to the next place, because otherwise touch feels intrusive without that purpose attached to it. And I think sometimes we can get caught up in the moment of, I wonder what's going on here, and not really relay that.
And you also mentioned pacing as well. So I think sometimes what people have been navigating with a chronic illness can be a lot. And sometimes there's a lot of information that we need to digest and a lot of questioning. So is it that checking in as well? Like, are we going okay? Is this enough? Do you need a minute, or is this enough for today even? Those sorts of things.
Yeah, and I think even just incorporating pauses in there without checking in, but just a moment for things to be processed and caught up, and then checking in whether there's any questions.
Yeah, because we're probably adding to it by asking a question as well. Like we've said a lot of information, and then you think you're doing the right thing by saying, "Oh, okay, so is that are we okay to keep going?" It's like, well, hang on, I'm just trying to process everything, and then I'm trying to help by asking, "Is this okay?" And it's just like maybe we just need is silence okay for a minute?
Silence is okay. Silence is okay. And this is the thing, is I think we want to fill the silence, but actually it gives brains a moment to catch up, to process what's happening, to check in with their body as best they can, and decide whether they want to go to the next step, so that when you ask that question, there is this connection with their body as best they can to be able to answer a true yes or no. But also that permission to not, really leaning into that permission to disengage or to stop there for the day. And sometimes, particularly as they get to know you and there is touch based, it can be a lot. So even having shorter appointments, having ways for the brain to process that might, if they haven't yet communicated, could you have a visual, draw a visual as you're doing it? Could you be noting down some points for them to take away with them? Not putting the onus on, particularly for ADHD brains, the need to remember everything that's being spoken about in that appointment. But within that, safety is those micro consents, the predictability, having a format for your appointment that they can expect and follow. So that might be that they come in, you do a bit of a debrief, you then move to any manual work that you're doing, and then you move back to the chair, you do a bit of a plan, and then you're off, right? But there is this expectation that this is how it's going to hold. And so there is predictability in that, which is safety for a neurodivergent, particularly for autistic folk.
I understand you do that even when you run workshops, is you will explain where are we heading, what are we doing today, at what time, when it's going to finish. Those things make a difference.
Yep. And the flow of the slides, I have this point where I wrap up each section and it always follows the same format.
Because otherwise, yes, I imagine that there's lots of brains trying to focus on what's coming next or where things are at and not necessarily on the content. How much longer is this going to be going on for?
When can I make a cup of tea?
Yeah, that's right.
And then probably even zoning out for a little bit and then getting stressed that you've zoned out because you're like, oh my God, was that important? Did I miss it? Yeah. Mm-hmm.
Mm-hmm. I mean, and I think what you're talking about a bit there in terms of that style of practice is giving people permission who are neurodivergent to start to unmask, which I imagine is quite tricky for a lot of adult women who might have never had the opportunity to do that before.
It is. It's very difficult. And quite often they don't know how to do that, right? And they may not even be aware that they're neurodivergent. It might be that you suspect or that they suspect, but they're not yet at that point. And then what follows is, well, what do I do next, right? And so all we're doing is creating an environment where the onus isn't on them to tell us, but on us to ask, us to check in around the transitions, micro consents, but also, would this be helpful? Would that be helpful? Not obviously all at once in a list of questions, but things that you might get to know in that first little space of time.
Mm-hmm. And we mentioned off air what's potentially useful for a neurodivergent brain is actually probably useful for most people anyway. So it should be part of usual practice to have this psychological safety at a level where it does, particularly when we're working with the chronic invisible illness and how what these journeys have been like, regardless of external trauma or neurodivergence, just navigating this chronic condition.
Yes, everyone in that boat needs safety and has been in a sea of unsafety, haven't they, if they're in a boat, just to continue with the dodgy metaphor there. In terms of, and I won't try and push it any further in terms of my next question.
I'm shutting that down. I'm shutting that down right now. We're not going to go there.
In your boat. No. I'm just curious on your thoughts around unmasking, particularly as someone who deals with a lot of people who are trying to confront, even to acknowledge that they mask. Do you have any tips for your patients around how to start navigating unmasking? Which if you're not familiar with the term, is sort of like if you're constantly reading what's happening around you and behaving in a way that you should or to be good.
Yeah, in a way that you perceive that this is what the other person expects you to be, say, do.
How do we stop doing that?
Asking for a friend.
And I think it's a long process. It's not a short process. And I think that engaging in some way with your neurodivergent community is important, right? In some way with others that are experiencing not necessarily the same thing. It's the acceptance of different brains and different ways of working. But also I think therapy is an important part of that. And it is not a short journey. I think how we can assist is to create environments where we are human, where we own our mistakes or where we just slipped up. It might be, I talked over you there, like that's on me, please say what you were going to say, right? Like, but what it does is acknowledge that our brains sometimes run away with us, or that, we sometimes are very human, and we're giving this permission to acknowledge that things might be different for them, acknowledge that they may not understand what's going on in this context or need additional information or additional time or just be really uncomfortable. And it starts to give them permission to be human. Because at the end of the day, it's that humanity, right? This is equitable care. And so that's where
I love that term.
Saying, yeah, when you were saying that, this serves everyone, it does, because what we're doing is saying, come as you are. Like, we'll make space for you. We'll adapt to you.
I love that. And I think you alluded to it, but it's that, that we are all neurodiverse. So you showing up as you are, you will be accepted for your own tics and nuances, and however you express yourself is absolutely, or not even absolutely fine. It's necessary so that we can, have turn this into a good experience and start to make our way forward and get some good outcomes that potentially you haven't even, considered.
And I think
we're all so excited.
Yeah, we're all so excited. I think in terms of that, Cherie, it's that lesson that women in particular often need to learn, that it's okay to take up space, because often we're so socialised to be reading what's happening around us and be that thing that we think that other people need or expect, as you say. A, is exhausting, but B, there is this sort of self-abandonment that can happen in that. And then there's probably all sorts of layers of self-abandonment that happen in pelvic pain, which overall is going to sort of completely dial up that nervous system and that experience of pain. Yeah, and sorry, just to pick up on what we said before, sorry I talked over you because I got excited about that. You were saying.
I love the excitement. And I think it's we are all neurodiverse, and I think, neurodiversity is kind of speaking to that, human differences between each other. I will say that neurodivergent folk, though, have had to experience something very different. They've had to experience their trying to adapt to a world, a brain, a medical system that has not been built for them and doesn't typically reward difference. It does reward a compliant, peaceful patient, right? And so in some ways, making space for the fact that this has been, probably quite traumatic at another level. But also, what you're saying there, Cherie, about the individual differences here are welcome no matter what they are.
Yeah, absolutely. And again, I hope that didn't come across as because being neurodivergent myself, that's definitely was not my intention. It was just more around that inclusiveness.
Yeah, and
is the main thing, the individual inclusiveness that we need to have. And if people have experienced, like neurodivergent people have experienced medical dismissal and medical trauma, like how important is it to address that and work through it? Like I can imagine that this is probably going to need some extra help in experiencing that.
Which is another little bugbear of mine, is the fact that psychology is quite often included far too late in pelvic pain. And I think it's not necessarily sometimes it's the reluctance of the patient, as in, I'm focused on the medical side of things, or I'm not stressed by it, or I don't want to be seen as anxious. Sometimes it's that clinicians are quite focused on the physical, the investigations, all of those things. So sometimes we can come in quite late, and it means that there is a lot of processing to be done. There is a lot of experiences that have maybe been misunderstood or have been very much understood have been quite harmful. And so it would be lovely to see psychologists included so much earlier as soon as we have any symptoms, because it's already having a ripple effect on the rest of their lives, right?
But especially if you've been experiencing, but if you have experienced, I can imagine that is a big influencer of dialing up that nervous system underneath, because I think that there, and correct me if I'm wrong, there's a sense of, oh, that happened, maybe it happened a few years ago, that's in the past now, like moving on. But, our body kind of doesn't, maybe holds on to that. It doesn't forget. And that can be still influencing our pain, even though we're not cognitively thinking of that. Like, what's your thoughts on that?
And this is the thing, is quite often the body is responding, right? It's not, the body's responding before the brain starts to try and make sense of it. And if we're in full fight, or freeze, there is no meaning making coming out of this or sense making. It is literally just a physical response to an environment or some sort of cue. And so it doesn't forget. And we do need to, it doesn't necessarily mean processing as in reliving that trauma, but certainly creating safety in the body again, so that it can navigate those systems in ways that are safer.
It sounds like you need some professional help potentially if you've had, like to help you. To be honest, psychologist. Yes, I know, but I think it's really important, because that's the other thing that we hear, and maybe that's that definition of psychology, is like, I just, I just don't want to talk about this anymore. I'm sick of talking about that experience that happened. But your potential, what I'm hearing is that that's not necessarily what you're going to do. There's different tools that a professional will take you through to help with this, again, you feeling safe within yourself and in your body, whether you're thinking about it or not. It did happen, and it's kind of still there.
Yeah, and I think one of the things that you say, Cherie, that I love is that the idea that there's no magic line that starts and finishes at the neck. Like the idea that the soul and the brain is separate from the body is just, it was made up from the beginning. It was made up for particular religious, scientific purposes, 400 years ago or so. There was never anything to it, but we all still carry that with us. And when you're talking about, Laura, earlier around not involving the psychologist early enough, whether that's from a GP like me or even the patient self-referring or thinking about it, is, I remember being a junior doctor quite some time ago now, but I used to get quite worried about even bringing up the idea of involving a psychologist because I didn't want the patient to think that I was dismissing them or suggesting that their pain wasn't real or that it was in their head. But then I also had some experiences where I perhaps introduced the idea in a way that didn't come across very well as a junior doctor. Hopefully I'm better at it now, that the patient also just didn't perhaps understand the role of a psychologist. Like, it's not about, kind of thinking about the things in a way that is disconnected, but it's actually, okay, if we understand there's a dial here and there's no magic line at the neck, what are our strategies? And there can be quite actionable, active, non-passive things that we can do that can make an experience, that can help us reduce our distress and reduce our experience of pain. Have you got any sort of, as we're running out of time, which we knew we would do, any sort of, I guess, winding up thoughts around your role in dealing with someone who's working with this sort of complex pain, who maybe wants to say to you, I'm not crazy. I just need some help with my pain.
I'm not making up my pain. Yeah, and how clinicians can potentially
hopefully that doesn't happen anymore. But
and how clinicians can broach that subject without feeling like that they're thinking that people are making it up, and how we can navigate those conversations.
Yes, which is obviously not true. Nobody's making up their pain.
No, gosh.
Yep. Yeah, and I think unfortunately it does still happen. But I think that if I was speaking to the patient, this pain has been happening, and it is created a sense of unsafety, lack of safety in your body, right? And so what we want to do is be able to make you feel safe in your body again, alongside all of your medical interventions, all of those things. But also, being in pain, having chronic health conditions, it has a ripple effect on so many areas of your life, and has emotional impacts, right, that you can work through in therapy to help support and navigate that process. And navigating the medical system itself, if it's a long process for you, is difficult, exhausting, all of those things. And so having that support in the background to be able to do that. I think also from a clinician point of view, it is about the safety and the, emotional and cognitive impacts of the pain and how we can create safety. And I think there are a lot of physios and exercise physiologists that do this beautiful job of creating safety felt in the body, starting to learn what those cues aren't the danger that they thought they were anymore, or whatever it might be. But I think we can also work at it from a brain, mind point of view and go, okay, well, like, how can we interpret these differently? How can we create safety and look for those safety cues in a way that is going to make this less stressful for me to navigate? I think too, there's a stage of readiness, right, for a patient as to whether they're ready to include that. And that's, again, up to them, right? It is always their choice, always their they're driving this ship, whatever we want to call it.
I think it was a boat, but that's okay. It can be
or a car or whatever you want to drive. But I think that's important. I tell people that a lot. Like, you are in the driver's seat here
of the boat.
Okay, it's a boat, sure. Whatever you would like, whatever vehicle you're in, you are driving the vehicle. You have total control over where you want to go.
Yes. If you're in a boat, though, you can only be in the water. But
exactly. It's very inhibiting.
Yeah, unless it's
We'll discuss this later off air.
Okay, good. Laura Grace, thank you so much for your time. This episode, we hope to be an introductory episode. We're not trying to cover the whole area of psychology. There's about 5 episodes that I think could easily branch off of this one today. So thank you for your job in at least starting the conversation on this. Very important
conversation. Is there anything you want to leave us with? Any last thoughts?
No, I think for patients, it's that they matter. Like, even if they've had experiences that are not what they hoped they'd be, there is somebody out there, clinician-wise, that really wants to make a difference to their quality of life. And so remembering that they matter. And their pain matters, and their safety matters.
Amazing.
Laura Grace, thank you so much for your time.
Thank you.
Thank you for having me.
Thanks.